Okay, good afternoon, everybody, and thank you for the GIS committee for inviting me for this very interesting meeting. So my case was about a vascular complication in alternative access TAVR. So it's about an 83-year-old female with a type 2 diabetes on insulin, hypertension, chronic kidney disease, stage 2, dyslipidemia, hypothyroidism. She was morbidly obese with a BMI of 44. And she was followed as a moderate to severe AS in the clinic. So she presented to our emergency department complaining of chest pain for a few days on top of worsening dyspnea on exertion and fatigue. Her presenting vitals, heart rate was on the higher side, 96. Blood pressure was 95/50. She was satting 98% on non-rebreather. She had elevated JVP and she was in pulmonary edema on presentation. Her EKG showed normal sinus rhythm with LVH and strain pattern, and her she got an elevated troponin, marginally elevated. The echo showed thick hypertrophied LV with moderate LV systolic dysfunction was 35 to 40%. Heavily calcified aortic valve, mean pressure gradient was 33, and a calculated valve area of 0.95 with an LVOT of 1.8. This is her coronary angiography, as you see here. She has a distal left main disease involving the proximal LAD as well as the mid LAD, and there is also a lesion in the proximal circ that will show in here, and also this first OM or ramus intermedius, which is minimally diseased. There is also an ostial RCA as well as a distal right at the PDA takeoff. It was a codominant system. We did a CT during this admission, so it showed an aortic annular perimeter of 67 millimeter, and she has a multiple atheromatous plaque and heavily calcified aortoiliac arteries, and the distal aorta was almost semi-occluded with good collateral flow. Her left subclavian was tortuous with tight calcified ostium, and the right subclavian was also calcified, but the lumen there was 7 millimeter. So we had a multidisciplinary team meeting, and she was deemed to be extreme risk for surgery, whether it's CABG or CABG and TAVR. And then the percutaneous approach was also entertained, and we also deemed her as a high risk. And the question was whether to go for PCI or TAVR or both. And because she presented with pulmonary edema, TAVR was, we felt that TAVR was the way to go. However, also because of the leak in the enzyme and the chest pain that made her present to the emergency room, we decided to go for both. Now, the question whether to use a mechanical circulatory support device was also entertained, but again, with this disease in the distal aorta, that was a challenge. And which axis we should use, and should we go for general anesthesia or monitored anesthesia care? So after multiple discussion, we decided to go for both, so PCI and TAVR. We use this algorithm in our hospital to make a decision whether to consider mechanical circulatory support device when we do protected PCI. So this patient had a high syntax score. Her systolic blood pressure was less than 100. It was an ACS presentation, and we were planning to do revascularization in more than 2 territories. And we felt that we might need a atherectomy device for the left main LAD part, and she was in decompensated state. So she had more than 3 points, and for that reason, we wanted to go with MCS from the get-go. So this is a document statement by Sky to use axillary arterial access, which is really relevant to this case, and it helped practitioners to plan procedures through transaxillary. And from this document, they suggest to use the left axillary over the right axillary because the curvature of that vessel is more consistent with the aortic curvature, and because the left common carotid comes, it does not come from the left subclavian, compared to the right side where the brachiocephalic gives the carotid and the right subclavian. So, but in this case, in this particular case, as you saw, the ostium of the left subclavian was also diseased. So we decided to go for the right subclavian. So we took the patient to the cath lab. We anesthetized her to have a controlled environment. And then we decided to go from the axillary artery from the left side. So, but just to walk you through what this statement document suggests is to go through the second part of the axillary artery, and they divide it into first, second, and third based on the relationship to pectoralis minor. So you can identify the second part by doing an angiography, and you see here the thoracochromial and lateral thoracic will give you the distinction between the first and second. And then the third part here, you have the posterior and anterior humeral circumflex arteries. So the reason behind that is because in the first part here, there is actually the close proximity to the brachial plexus and to avoid injury to the brachial plexus. And in the third part here, because also the median and so the median nerve actually runs in front of the artery when you access it. So that's why second part is the way to go. So and they recommend also to have a secondary access site, whether you use the ipsilateral radial or you come from the femoral. So this is what we did. We went through the ipsilateral radial and we identified the area where we should puncture. We had our wire back there. We did the micropuncture access, and it's like the usual micropuncture approach. We passed a small wire there. We took a picture. We are in the right place. And then we dilated that axis, and then we went with then crossing the valve from the right side is a little bit more challenging compared to when you come from a femoral side. So we used actually multi-purpose catheter to cross this tight aortic valve, and then we managed to do that. And then after that, we put the impella in place, and then it was straightforward multi-vessel PCI. So in the RCA, we did balloon angioplasty followed by drug-coated balloon to the distal and mid-RCA. And for the proximal RCA, we did drug-eluting stent. And it was a final good result for the right coronary artery. And then we switched gears and dealt with the left system. So we did we prepped the lesions, and then we did drug-eluting stent to the mid-LAD, and then we ended with the DK crush to the left main LAD circ. We had a good result, although there was an impaired flow to that ramus intermedius. It was a good result. Then we pulled our equipment, and we went for the TAVR. It was an uneventful TAVR. And then this is where the problem started. So we did dry balloon compression, and then, as you see here, there was a leak there. So what actually bailed us here is that we had an access from the secondary ipsilateral side. We brought a covered stent, self-expanding 6 by 50, And we took a picture. After 10 minutes, there was still a leak there. And we went with a second. I just need 1 minute. 1 minute.
One minute, please. Nobody at the back?
1 minute, yeah. So we waited for 10 minutes, and as I showed here, after 10 minutes of waiting, there was still a leak, and because of her body habitus, and it's difficult to actually appreciate that there is actually a bleeding at that side. So we decided to go for a second covered stent, which was a 7 by 38 balloon expandable covered stent, and that was inflated in place, and eventually we got it sealed. And we did not block those humeral circumflex arteries because there is an associated risk of avascular necrosis if you do that. And looking at the document, it says that there is actually more elastic lamina and less muscular lamina, which leads to a phenomena of pulling through compared to the femoral arteries. So that's why what we actually did wrong, probably we pulled out a little bit the usual way, although we have to go more gentle on the axillary artery compared to the femoral artery.
Excellent. Thank you.